Welcome to Cardiology Section 8. Follow with us as we review syncope.
Alright, so when we're talking about syncope, when somebody gets syncope when they stand up, you should be thinking orthostatic right away. This is the drop in systolic of 20 or diastolic more of 10 from a laying to standing or sitting to standing position. Syncope when they're shaving, we're thinking about carotid sinus hypersensitivity. Often this is somebody who comes in after passing out, they're sitting down, the doc will actually go over and do a carotid massage and see if it causes bradycardia. So that's what they're talking about. They say syncope was shaving. In the olden days, when you would shave with that straight razor, you could push on your carotid and cause yourself to pass out. Now, it's just when somebody passes out, you come in, we do a carotid massage, look for the bradycardia. That's likely the cause of your syncope. They need a pacemaker. Syncope during an argument, if it's an older patient, you need to think about a heart attack. If it's a young person, then think of long QT. And then syncope with prolonged motionless standing, it's often neurocardiogenic or vasovagal. Sitting on the toilet, pooping, patients who see blood, those are usually neurocardiogenic syncopes. Remember, with orthostatic, you got to check the blood pressure in 3 positions, and you know the changes here. Fluids treats it. Carotid sinus massage, they become bradycardic. Remember to auscultate first, listening for the bruit. If you're a bruit, do not auscultate because you can break it off, cause a stroke. Myocardial ischemia, of course, you're looking for the EKG findings. And then the neurogenic syncope, this is done with the tilt table test. This is how you see if that was the cause. If they have a positive tilt table, then you know that's the cause of their syncope. This is something that you can look at with children who have syncope, long QT, hokum, anomalous coronary artery, and pre-excitation. You can base it on if they passed out, they all do, whether or not they have chest pain, and what their exam findings are. So remember, with hypertrophic cardiomyopathy, they'll have syncope, they will have the chest pain because they get the big heart muscle, and their exam will be abnormal because they'll have the apical impulse. Whereas somebody with long QT, they'll pass out, they won't get angina, and their exam will be normal. They'll just have the long QT on EKG. Anomalous coronary artery, the difference between it and long QT was that they have the syncope, they'll have the angina, but they'll have a normal examination, where this guy had no angina. And then the pre-excitation syndrome, they pass out, no angina, normal exam, but they'll have the short PR interval. So long QT and pre-excitation, these two are an arrhythmia problem. Short PR, long QT. Here, thick muscle. Here, artery is connected to the wrong part of the body, wrong part of the heart, actually.